Okay, so I'm going to go ahead and get started. So today's webinar, discussion, whatever you want to call it, is going to be about ketamine-assisted psychotherapy. And this is basically what I think that every clinician or any potential client should know when they're choosing a provider. Um, just a little bit about me. Maybe, let's see if I can get to the next slide. Okay, so who am I? My name is Dr. Kimberly Lee, go by Kim. I am kind of a unique situation. I am retired military. My doctorate is actually in sports and performance psychology. And then I went back to school for a postmaster's certificate in clinical mental health. So now I'm a licensed professional counselor and a mental health service provider. I'm also a somatic experiencing practitioner. I practice EMDR. I am an applied suicide intervention skills trainer or assist. I'm trained in voice dialogue, which is similar to internal family systems. I'm kind of a geek. This is how I describe myself lovingly because I love to learn. So I've probably dabbled in just about most modalities. I'm trained in dialectical behavioral therapy. But I started working with psychedelics in 2018. And at the time, I started because I was struggling with PTSD and I was looking for a way to heal myself. So as I'm talking about my work with psychedelics or my work with ketamine, I'm talking about my work not only as a clinician but also as a patient. And so this is why I both see how beneficial it can be, but I also see the pitfalls. And that's what today's discussion is about, because some of the things that I think are going on in this field, I would call unethical, but definitely in the gray area. And so this is why I want to talk about some of my concerns so that if you are recommending this to a client, you can tell them what questions to ask, or if you're considering it for yourself, what questions to ask. It looks like most of us are clinicians just based on the registration. Disclaimers that, this is education. This is not medical advice. So if you are seeking ketamine-assisted psychotherapy or ketamine treatment, and I'll discriminate the difference, this is not medical advice. And of course, this is true of anything. You would need an intake, that sort of thing. My second disclaimer is that while I do believe that ketamine can be a very powerful tool, it is not magic. It is not that pill that you take or that injection or this IV that you take and then things are just miraculously better. And that's part of why I wanted to have this talk today, because I think that some of the way that it's presented, it is presented as kind of that magic pill. And so what I want to talk about today is that good outcomes depend on so much more than just the medicine itself. And this is an audience poll since I'm doing this alone. There is no audience, but like I said, I think most of you are clinicians, and I'm assuming you're busy tonight. Either way, I'm going to make sure you get great information. And then, what is ketamine? So I'm not going to bore you with all of the ins and outs and how it works in the brain, but I'm open for further questions. You'll have my email if you'd like to do a consult to learn more about it. But generically, I'm going to tell you that ketamine was originally developed as an anesthesia. What they found, it started on the battlefield during Vietnam. And because most anesthesias, they suppress the respiratory rate, they repress the heart rate, and it takes equipment to keep those things going. And with ketamine, it actually will increase the respiratory rate. It will increase these things. And so they found that they didn't need all the equipment on the battlefield. But what they also found is it had these beautiful side effects. And so the side effects are essentially what we're going to talk about today, because things like pain management. I'm not going to talk to that specifically. I'll talk about it a little bit from the mental health standpoint, but what I'm going to primarily talk about today is the off-label mental health usage. And by off-label, it means it is FDA approved as safe, but it was not originally approved for mental health treatment. And we'll talk a little bit about why that's important later. So why is everyone talking about ketamine? The big thing is that, as we know, like when people start taking antidepressants, it takes a while for it to build up in the system before you start seeing the effects of the like antidepressants or mostly antidepressants. With ketamine, you can often see the elevation in mood almost immediately. Like a client will come out of just the dosing session and they will have an improved mood. So you will see noticeable effects within days or hours even. But the thing that I want to highlight on this slide is that symptom reduction is not the same thing as healing. And this is where I think some of the what I will call unethical practices come in, because you will see that with the dosing that their symptoms start to improve, but just as quickly as you saw them come on, generally the period for the effects to start to wear off is 4 to 6 weeks. And so you will hear a lot of clinicians, and when I say clinicians in this respect, I mostly mean prescribers. Whether it's nurse practitioners or doctors or psychiatrists, they'll say if your mood starts to dip, just come on back for a booster. And what I'm going to talk about today is typically, not always, the mood will start to dip because the biochemical effects start to wear off. And so while there may be initial symptom reductions, it isn't always lasting. And that's what I want to talk about today. And so how does ketamine work? And again, I'm not going to go through the whole ins and outs, but most antidepressants, as we know, they work on the serotonin receptors. Whereas ketamine kind of has a combination of receptors that it works on, but bottom line, what it ends up doing is releasing glutamate into the system, and it works in conjunction with a couple of other neurotransmitters, and that's where you get this mood elevation. But what it will also do is it biochemically creates new neural pathways, and it will, and where this is important is, as you know, like in our I'll call it typical standard therapy practice, what we are trying to do is create a neural pathway that is stronger than the neural pathway where the dysfunctional or unhealthy beliefs reside. So if say there's a child that has a childhood trauma, they may start to believe I'm not lovable, this is my fault, these sorts of things that resides on a neural pathway. And what we're trying to do through our standard therapy is we are trying to mechanically create a new neural pathway that is stronger than that neural pathway, because that neural pathway doesn't go away. But I'll talk about this a little more later, but the important part is, okay, what are we loading onto these new neural pathways? What beliefs are we loading? And so this is where the work comes in, because there are what I call spontaneous insights, that they come just by sitting with the medicine, but generally it's working with the belief systems. This is where things like CBT and DBT and cognitive reframing and this sort of thing comes in. Because in our traditional therapy, we're combating life, and clients may be coming in once a week, may be coming in every other week, once a month, but the frequency is not enough to counteract the reinforcement that they're getting from their environment. So, but with ketamine, it is biochemically creating these new neural pathways much quicker, and then we're helping them to load the new belief system, the healthy belief system onto these new neural pathways. It will also because it temporarily suppresses the default mode network, which is responsible for that automatic negative thinking, the rumination, a lot of, like obsessive compulsive behaviors. And so it temporarily suppresses that. It kind of opens this door for new ways of thinking. It decreases the rigidity, the set ways of thinking. And so what I tell clients is that we've opened this beautiful window. We have these new neural pathways to work with. We have the default mode network temporarily suppressed, so we've opened a window. And what we do in this window is what is important. Okay, so what is ketamine-assisted psychotherapy? And this part, I really want to foot stomp this because where I get frustrated is that a lot of practitioners will call things ketamine-assisted psychotherapy, or they'll call it CAP. You may hear CAP, and it's actually not. Because if say it's the same with, and this is no slight to psychiatrists or nurse practitioners, but a lot of them don't actually do therapy. What they do is med management. And so when we talk about ketamine-assisted psychotherapy, like a prescriber may prescribe the medicine, they may come in to get the medicine, and then they inaccurately call this ketamine-assisted psychotherapy, and it's not. And so what is ketamine-assisted psychotherapy if that's not what it is? So a true ketamine-assisted psychotherapy, in my opinion, will include 3 phases. There's a preparation phase, there's a medicine phase, or the day that they actually, get the medicine, and then there's an integration phase. And in the preparation phase, and even this is done differently at different clinics. And so I want to kind of outline, and again, this is Kim's opinion, although I've seen like how it works in conjunction with clients and how it works best in the results and the outcomes. But in Kim's opinion, the way it works best, there will always be a medical clearance. And this is saying, like, are there any contraindications, any medical reasons we wouldn't prescribe this to you? Is this medically appropriate? And they will also look at, like, what other medications are you taking that may interact with the ketamine that would make the ketamine less effective? And they will go through things like that. So some big things are because ketamine does raise the blood pressure. If there's uncontrolled blood pressure issues, then it is usually contraindicated. So they like to get the blood pressure under control before they would do this. Also, because everything does run through the kidneys, if there are kidney issues or that sort of thing. And again, I'll talk a little bit more about that a little later, but these are generally the things during the medical screening that they would screen for. In the mental health assessment, and we'll talk about this, as a ketamine-assisted psychotherapist, what I would be doing is going, okay, is there a diagnosis? What have you tried before? And it's interesting because I am retired military. I was stationed in Europe. And there's a huge difference between the way the U.S. treats what have you tried before and the way that a lot of the rest of the world treats what have you tried before. Obviously in the U.S., if you've tried multiple antidepressants, they consider that I've tried therapy. But I would argue as a clinician that if we don't need this medicine because it's very expensive, then I don't recommend it. I say let's start with traditional psychotherapy, and let's see what results we get through that. And then if I think that it is appropriate to then use this tool or to use this medicine, then I would recommend it. And some other, contraindications, it's not contraindicated if there is a bipolar diagnosis, but generally because of the way it excites the system. If they are in the manic phase, we typically would not do sessions, not dosing sessions during their manic phases. Active psychosis, these sorts of things, they can create a psychological split. And so these are things that we would discuss. And obviously as clinicians, we have to say, what am I qualified to treat? do I have, training with these and feel comfortable dealing with different diagnoses. I've seen clinicians work with different diagnoses, but there's also what is evidence-based and what is more clinician-based, like autism, for example. I've seen it used with autism, but there is no clinical research, and it's not prescribed for things like people on the spectrum. And so these are things that we would talk about in our clinical assessment. Other things that we would talk about, we would go through, because a lot of times this is prescribed for people with PTSD. And so or pain management. And what I always look at, because as a prescriber, a lot of times a prescriber will say, oh, there's fibromyalgia, I'm prescribing it for this, or I'm prescribing it for this pain issue. But as a clinician, as a therapist, what I look at is, what is their ACE score? I've had, clients who will come in for 2-hour dosing sessions, and the prescriber will say, oh, they're just here for pain management. And when I start to look at their ACE scores, and they have a 9 or a 10 out of 10 on their ACE score, there's obviously research that shows that our mental health and our body are connected. And so while one does not necessarily create the other, like a high ACE score isn't necessarily the only cause of pain, but it will definitely exacerbate it. And it also tells me, because a lot of times what these clinics will do is they will stick the patient in the room by themselves for 2 hours, and because they say, oh, it's just pain. But as a clinician, when I look at their ACE score and I see a high ACE score and I say there's a significant history of trauma, then my recommendation as a therapist would be, we don't sit them in a room by themselves, because I have had issues where they put them back in a room by themselves. They have flashbacks, which can actually be re-traumatizing. And so the way that people view the medicine and how the medicine is used is different can be different between some prescribers and some people who do ketamine-assisted psychotherapy. So I want to highlight that, because I would say that probably 80% of the time it would be, and I'm just going to say okay, to leave them in a room by themselves. But even like sometimes the medicine comes on quickly, and even having someone to and in psychotherapy, touch is a little different. The way that I was trained is that by denying touch can actually be unethical. Like when they start to kind of drift into the medicine, especially at higher doses, sometimes it can cause panic attacks. And if they're left in a room by themselves and they start to panic and they're hooked up to an IV, that can be dangerous. And so this is why I like to look at things like ACE scores, their trauma history, what are their belief systems, before I just put them into a room by themselves with medicine. And so a lot of this education is, what to expect. When I get into the room, what can I expect? And of course, every session is completely different. Even if we lay out our intentions for a session, it's like the medicine in the mind and the psyche, it sometimes has a mind of its own. So we can say, this is our intention for today, this is what we're going to work on, this is what we're going to sit with, and your psyche takes you where your psyche is ready to go. And a lot of times the psyche is more ready to go when there's a person sitting there and they know that if something goes sideways, then I have someone here that is going to support me. So even from a perspective of how much work they can do in a session, it's greater when they are with someone in a session. And I think a lot of prescribers, and again, I'm not trying to bash prescribers, but they don't understand that the depth that you can go to is much deeper with a prescriber or a therapist in the room with the client. Part of this preparation too is also a patient-centered treatment plan. And this is where, and you're gonna hear a lot of my frustrations, but this is where a lot of my frustration comes in, because there is no treatment plan. They basically come in, they say, I'm depressed, I have anxiety, I have PTSD, whatever the diagnoses that they're coming with. And then it's like, great, let's get you, an infusion, and this is, not the way that therapists work. This is not the way that we get the best treatment outcomes. And so through this preparation session, and I like to do at least a 90-minute intake, if not multiple intakes, because again, if the medicine is not medically necessary, I like to do as much work as I can without it, because it is very expensive. And I'm sure if you've looked, there's a huge range. Some I would say are on the lower end. They're just trying to help help clients. They're in the 300 range, and then I've seen up to $1,200 a session. And so it can get very expensive, and if you're not getting the best clinical outcomes, this is where I think it starts to become unethical. And so we lay out, what are my intentions for these sessions? What are the belief systems that I'm working with? What is the trauma that I'm working with? And in this building safety, we talked about that. Sometimes the safety is both self sourced safety, but also the safety of having a person, literally within an arm's reach of you, that'll help to establish that. And this last one, as I mentioned, I'm trained in voice-led dialogue. I do a lot of IFS. I do a lot of parts work. And one of the things that I always ask a client is there a part of you that is nervous to go into the medicine? Because, whether it's a control part that doesn't want to let go of control, or there's just a part that holds fear around what's going to happen. And I like to talk through that, because while you can biochemically override those parts, I consider that very violent to the system. And so I like to talk to those parts, and that's where the voice dialogue comes in. And I like to go, okay, what are you afraid of? What would make you more comfortable to let go of control for, an hour, 2 hours. And then through that, we start to establish comfort in the system, and it becomes less violent to the parts, less violent to the patient's system. And then during the medicine session, so there's different modes or routes of administration. Typically, there's the oral administration. It can be taken either through rapidly dissolving tablets, or what you may hear is called troches, and it's taken orally. There's different ways to do that. Generally, I would recommend you swish for 15 minutes. It will absorb into the mucous membranes, and then you spit it. And part of the reason, I was trained, I've tried both ways, because I have tried it to see how it works. And what I find is that when you swallow it, it's unpredictable when it's going to go through your digestive system, when it's going to hit you. And so you don't want medicine sneaking up on you. And it's also I did not find it as a useful pass. Like people will call it the second pass. So there's what's absorbed in your mucous membranes, and then there's the second pass as it goes through your intestines. And I just didn't find it to be therapeutically beneficial for that second pass. But what they can do, if they're doing it, is they can spit it into a cup. And then, they can even basically re-swish it at another time. And I know that sounds kind of disgusting, but I've actually tried this and it actually works. But, it depends on how much time you have, how much work you want to do. But you can re-swish it. And actually, I've done that, up to 3-4 times. I think beyond that, it starts to become more spit than medicine. But you can extend a session, and if they're doing it at home, they can extend a session by doing it that way. There's also intramuscular, which is a shot. The big thing about either the shot or the IV is that through absorption through your mucous membranes, it's not as bioavailable. So you're not getting as much of the medicine, and it's a little less predictable on how much medicine you're getting. And with the IM or the intramuscular shot, what I love about it is that if I'm doing somatic work or they're not hooked to an IV. But what I do like about the IV, especially if there's an infusion pump, and these are all questions to ask because a lot of clinics will use what they call gravity fed, but they have a flow meter. and you can turn off the flow meter, and within about 5-10 minutes they're completely, back to normal. They still can't drive themselves because they're still under the influence, but for the most part they're cognitively present, they're able to converse in a normal way. And so these are generally we have oral, we have intramuscular or IM, and we have IV, but and then within the IV some people use an infusion pump. It gives you a more steady flow. A lot of times if you move your arm the wrong way, what was supposed to be a 40-minute bag can turn into a 90-minute bag, which will influence, like childcare, that sort of thing. But even the how long your session is. And then there's, so I'm going to talk about this next one, different compounds. And so you may have heard Spravato. And it's basically like an inhaler that they will squirt up the nostrils, and it's a different compound. And I would say that just in the work that I've been doing with clients, the issue with this one is because it's a different compound, it has done its own research to get FDA approval, and it is approved specifically for mental health conditions. The problem with it is because it is a slightly different compound. I personally have not seen the same results with the other compound. And a lot of times, again, what therapists will do is what clinicians or prescribers will do is they will have them administer it, and then they sit them in a room by themselves. And a lot of times, I'll get to that part. But so low versus high dose sessions, and we'll talk about this a little more later. But in psychedelic therapy, there's what we call psycholytic sessions and what we call psychedelic sessions. In this case, generally speaking, most psychedelic-assisted psychotherapists don't consider ketamine a psychedelic. They consider it a dissociative drug, which means it's like out-of-body type experience. But for these purposes, I'm going to talk about low dose versus high dose. So with high dose, the client is really kind of gone. They are unable to converse. They are having more like what I would call like spiritual experiences a lot of times, and there's not a whole lot of therapy going on during this. This is why a lot of times people will recommend what they call a sitter. So it's just someone to sit with them in case something goes wrong, but not necessarily a therapist, because there's not therapy going on. And this is why I even tell clients, if therapy is not going on, paying for a therapist doesn't make sense. Like if you just want someone to sit in the room with you, bring a friend, bring a partner, bring a spouse, whatever it is, and just kind of, they can do grounding. They can offer a hand if you need to be grounded. And by grounded, I just mean sometimes when they start to panic, when they start to come out of body, and grounding is just kind of like reestablishing safety, kind of bringing it, like just the touch alone will bring them back into the body. And sometimes they need that temporarily before you let them slide back into the medicine, or sometimes you may need to turn off the medicine completely. And that's the thing with IM. Once the shot is in, there's no bringing it back. Once it's in, it's in. And it does tend to be a quicker onset, whereas the IV tends to be more of a steady flow, and it tends to be a gentler, I call it a gentler ride. But when I talk about, people will talk about bad trips. And when I talk about bad trips, the only, bad trips are not difficult trips in my mind. Because I've seen people have very difficult trips, lots of emotion, but if there's a therapist with them, that is not a bad trip. What I consider a bad trip is either there's an adverse reaction to the medicine itself, so a biological, reaction to the medicine, or it's unsupported. And this is what I'm seeing, is that a lot of these sessions are unsupported. And so those can be bad trips. So this is where I think that therapeutic support is hugely beneficial. Integration. So generally what I will tell clients, and this is because, and this kind of relates to my work with EMDR, is that right now, you've basically, a lot of times you will bring things to the surface, because the good thing about ketamine is that I also call it a therapeutic lubricant. So things like even with the medicine, I generally will work outside of the window of tolerance because I'm there with them. Like the relationship is what they're working with, and this is just how I was trained, the modalities I was trained in. But you can allow them to go outside the window of tolerance. And so it's kind of a lubricant for the psyche to go, okay, we're ready to work with that. We're ready to, we're going to stop controlling it, stop suppressing it. We're going to actually bring it to the surface. But what I will tell clients, because your brain is now processing it, and even in your sleep, you're processing it. And sometimes because the story around the trauma has been there for so long that they will automatically come back to the story, or they will say, oh, this is what I processed, and I try to steer them away from any meaning making immediately after the session, unless it's something that they absolutely want to anchor. Like they've had this insight that they want to carry forward, but sometimes making meaning too quickly can actually stunt the growth of what is unfolding. And so what I will generally recommend for a client is, if you want to anchor something, let's talk about it. But the real integration, generally, I recommend it happens the next day. And that can happen by telehealth, so they don't have to drive in again. But generally, the cognition is kind of a little stirred up, and it's kind of reorganizing anyway. And then the next day, what I will ask them is, what is still active? What is still alive? And I, kind of, caution them against going back to the story because it's habit. But the good news is with that default mode network suppressed, they are able to see what is actually present. And we will check in with the body. Okay, what is the body telling you? This sort of thing. But we also talk about, the belief systems. We start to load those new neural pathways. And so this is where a lot of the benefit comes in, is through this integration. But a lot of these clinics, because they don't require a therapist, there is no integration. Essentially you just come back in for your next session, and then a lot of times, because the client is not working on these things actively, then they end up spending a lot of time on the same material. Whereas if they had a clinician, and that could be you recommend they go get their boosters or their sessions. They come, they do integration with you, and then you're covering a lot more ground. Whereas if they're just coming to get the medicine, they're just getting temporary relief. And I will say that this is kind of my belief on, I would say most mental health medicines, it's like, oh, I feel anxious, let me pop a Xanax. And the thing is, like, I do think that sometimes they are necessary to take off the edge so you can do the work. But ultimately, with most mental health meds, like, my goal is for them to feel what they need to feel, and to process it through the body, and to process it through their neural pathways, so that we are creating new neural pathways and new experience in their body. And so this is where we start to even, bring in these new insights, because integration, like a lot of times when even, like fellow psychedelic assisted psychotherapists, a lot of times when they talk about integration, they talk about tools for integration. They talk about journaling, they talk about, like meditation, they talk about, whatever it is. But those are tools for integration. So my the way that I view integration, it's like, okay, so you have this new experience, this new insight, this new belief. How can we anchor that into your new way of showing up in the world? And so that is what I call integration. And there's integration trip books that you can buy online and that support that process. But the big thing, and again, I want to foot stomp this, and I'll probably say it like a bunch more times, but boosters is probably the biggest thing that frustrates me, because when a lot of people ask prescribers, when do I need to come back in for a booster? They'll say, oh, if your mood starts to dip, just come on back. And what I tell my clients is, if you are doing this work during this window, you may never have to come back. And that's not true for everyone, because I would say there's layers to trauma and we may be working on a different layer. But the thing is, if there's not a treatment plan, and these things are not, the outcomes are not being tracked, and we're not tracking therapeutic goals, like, to me, it's very expensive and they're not getting what they're paying for. And so this is why I will continually tell clients, like, if you're gonna spend this money, because a lot of times this becomes a money conversation, like, because the medicine is so expensive, I can't also afford a therapist, and honestly, because I'm retired military, I don't need the money. I just want to get some pay for my time and my effort, and so I will tell clients, tell me what you can afford, because I don't want you to do this medicine without the proper support, because otherwise you're throwing your money down the drain. And so that's the gift that my military retirement gives me. So I like to pass on that gift. And then this is what I always say, it's ketamine loosens the soil. It will open this window, but it's the psychotherapy that really determines what grows in this soil, what goes on these new neural pathways. And so this is why I think the psychotherapy in conjunction is so important. And then who may benefit? And so we've talked about this a little bit. And like any antidepressant, we know that once the mood starts to elevate, like, this can be a risk period for suicidality. And so this is why, and again, treatment-resistant depression, like, when I evaluate treatment-resistant depression, I evaluate it differently. PTSD, again, I'm working with the belief system. I'm processing the trauma through their bodies. What I learned in SE is a lot of times during these traumas, they were not able to do certain things to process it out or to reestablish safety in their body. And so a lot of times this is how I'm working with the medicine, is to reestablish that sense of safety, to work with the belief systems. Anxiety disorders, and this one can become a little tricky, because a lot of times the excitatory response of the ketamine can feel like anxiety. So even helping them to discriminate between, this is what's going on in my body, and it doesn't mean that it's anxiety. It could just be the excitatory effect of the ketamine itself. But again, I'm working with the belief systems. So anxiety is generally caused by a belief system. It's social anxiety, I don't belong, these sorts of things, or, this rumination. So these are the things that I'm working with. End of life distress, I've worked with that. And then again, certain chronic pain conditions. But this is where I would caution, like, if you hear someone, whether it's a friend, family, anyone, talking about going to get ketamine for pain, it would be beneficial to also ask them about trauma, because if they think that they're going for pain, a prescriber will prescribe them. They will sit them in a room for 2 hours, and they may not ever ask about their trauma. And so this is why, like these are just the questions that we can support our community with, so that they are asking the right questions. So there's some potential contraindications, and I've talked about these a little bit. You have to excuse me, I am neurodivergent, so my thinking is not exactly linear, and I tend to talk about it when it comes out of my brain. But active psychosis, again, not during the manic phase. You want controlled blood pressure. But also in this one about active substance misuse concerns. So this, I think, is important, because a lot of people, because it is legal, it can be prescribed, and this can be kind of a harm reduction issue. Like, okay, at least they're coming into a supervised situation, but it may not be what I would call supervised. Because if I find that clients are just coming to escape from whatever's going on into their world into an hour session or a 2-hour session, like that to me is still substance misuse. And a lot of times if we're not asking those questions, we're actually perpetuating the issue instead of helping them with the issue. You want to work with the underlying issues versus just setting them up for dependency on another chemical. Because I will say a lot of these clinics will happily take their money. They will happily give them boosters whenever they ask for them. And typically, and I didn't mention this in the beginning, but typically because of the dosing, what they generally recommend is 6 to 8 sessions, over the course of 2 to 3 weeks, because it is a cumulative effect even with the ketamine that is doing all of these things in the brain. And if you start to do the math, like I would say, like one of the clinics in town, they charge $600+ per session times 6 to 8 sessions. Right there you're looking at $3,600 or more just for the medicine. And so this is why I'm going, like, this is a really expensive antidepressant if that's the way you're using it. This is a really expensive escape if that's the way that you're using it. And so it can be just switching them from, street drugs to clinic drugs. And so, like, this to me is not the way that we should be helping our clients. This last one, and even from a logistics standpoint, this last one comes in because, like I said, they can't drive themselves home afterwards. And they can call an Uber. They are perfectly within their faculties. So I generally would not have a concern with it. But where I have a concern with it is there are clinics that I call them drive-through clinics, where they have multiple treatment rooms. They're pushing clients out, like it's a 40-minute bag, sometimes more, on the hour they're pushing them out. Sometimes they're taking them out to the parking lot to go home before they're even fully in their body. And so, that would be the only time I would have concerns about them calling an Uber. But they do have medical Ubers. But from a logistical standpoint, they will generally need someone to drive them and then to pick them up. Or, they can come get their car the next day, but they generally will need at least a ride. And then, it can kind of wipe you out. And I mean, just, it's doing all this work in your body, so they can be tired afterwards. So, even, like maybe I get a sitter, maybe I, have, someone come over just to be with me after my session. So that's where I would consider inadequate support, but I would also consider a therapist part of that support. Okay, so these are the questions that I would recommend that every person considering ketamine, or if your client is considering ketamine, that they ask. And these are asked a little differently because a lot of times they will volunteer things, but they don't give the whole story. Some clinics don't give the whole story. It's like, how do you evaluate whether I'm a good candidate? Because like I said, some you just come in and say, I'm depressed, great, we'll set you up for an infusion. And it's like, okay, well, how did you evaluate? What did you consider? Did you consider that there are, because I've seen, them prescribe it for people with intellectual disabilities, developmental disabilities, autism, pretty much anything you can think of. And sometimes they're overzealous prescribers, and I'm sure we've even seen this, with our other mental health meds. But the how do you evaluate whether I'm a good candidate is a good question. What are the risks and contraindications? Typically they're going to be getting that, but just make sure they're asking, what preparation and integration support is provided. And like I said, if they just do a medical intake and then they say, come back on in for your infusion, like that to me would be a red flag. Like that to me would say, okay, like maybe I'm not getting the treatment that I'm paying for. And this integration support, you don't want to cover the same material like over and over, like that's not getting, your value for your money. But also how, what outcomes are tracked? How are they tracked? What measures do you use? Like a lot of prescribers use like the PHQ-9. It's just, are you feeling better? And again, symptom reduction is not necessarily healing. And a lot of them don't do anything. They just go, oh yeah, you look better, And so this is where I go, okay, this is not ethical, what I would call ethical treatment. This next question, how many treatments do you typically recommend and why? I did mention that there is a cumulative effect, but a lot of prescribers will say, 6 sessions, this is what the research shows. Well, the research actually doesn't show that because they based it off of the TMS model. And, TMS does 6 sessions, and so therefore ketamine did 6 sessions, but there's been no follow-on that I know of, I will say that I know of, studies that show, will 1 session do the trick? Will 4 sessions do the trick? And so a lot of times this 6 is just a kind of a number that, this is what they did the study with. They haven't done any, what's the optimal number? And so 6 is, and like I said, sometimes you do layers, and so more can be required. And then this next question is one that I think I've never heard asked by a prescriber. It's like what are some red flags that would tell me that I'm taking it too often? And I will say, I have friends that that they get it mailed to their house. And I've started to ask them these questions because, I have friends that have been doing it for a year, 2 years, multiple times a week. And in oral ketamine, it is less ketamine that's getting absorbed in the system. But, I'm going, okay, are you actually working on a new layer? Are you actually working on something new? Is this an escape? These are the questions that I have even asked my friends that are using it. Because I think, it can become an escape. And if you're not integrating what you've already, kind of stirred up, you've already started to work with, then you're actually just wasting your money. So some other questions, like we know, as the mood starts to elevate, a lot of times, the suicidality risk can increase. And so, how is suicidality managed? Most of these clinics will just give you, here's the crisis number. If you start to have these thoughts, there's no check-in or anything. And so just asking, I'm only guessing that the answer will be that here's the number, here's a lot of them will generally just give them a sheet, if you start to have thoughts of suicide, the standard sheet. So this is something to think through with them, if this becomes an issue, do they have a support network? And these next questions, what happens if difficult trauma emerges? Because, like I said, a lot of these clinics leave them in a room by themselves, and some of them will give them what they call a call button. If something comes up, just call us. But again, at different doses, they're not even able to really move. Must push a button. Because it's usually on a side table. They have to reach for it. And so that's not always practical. Some of them will put an O2 monitor on them. Some of them will consistently monitor blood pressure. Some of them, just kind of pop a head in every now and then to check. Some of them do nothing. And so, these are questions to ask, if my blood pressure does start to spike, how are you monitoring that? Because sometimes it will make you nauseous. If I start to vomit, how is that handled? How are you going to know that happens? Even if, minor things, if I have to pee, and I'm hooked up to an IV, how do I, manage that? So there are a lot of considerations that just to think through, how is this going to be handled? Some other questions is who is involved in my care and how do they communicate? A lot of clinics that they may have a CRNA because they are administering anesthesia, or they could have a doctor, or they could have a psychiatrist. Depending on your state, it could be a nurse practitioner prescribing and administering it. And sometimes that's the only person. There may be a billing team, there may be a front desk person, but it's who's involved in my care? Is there a therapist? And then the next question I would ask is, even if there is a therapist, what training does that therapist have? Because when I did my internship, I did an internship in a clinic, and I think we had 12 or 13 therapists, and myself, the clinical director, and one other person had any training in psychedelic assisted therapy. And our ethics code says we won't do anything that we're not trained in. And so, like, again, I would consider this unethical, like doing things that you're not trained in. But what I would see a lot of times with these untrained clinicians, and they would just basically try to do like a standard therapy session while they were under the influence of ketamine. And while that can be done, there's specific like techniques that you use in conjunction with the medicine, and sometimes allowing them to slip into the medicine and allowing the medicine to actually work, especially at higher doses. Because what you're doing is keeping them in their cognitive brain, and you're not allowing that reprocessing. You're not allowing that, you're kind of keeping them in the rigidity sometimes. And so this is why, like, someone having training in learning how to work with the medicine is important. And a lot of times people have zero training, and they're still providing what they call ketamine-assisted psychotherapy. And then again, this next question, like asking, what happens if symptoms return? And a lot of times the answer will be, oh, if your mood starts to dip, just come on back and get your booster. And what I find frustrating about this is a lot of times clients will see that as their failure. Because a lot of times if they've tried other modalities, they see this as a last resort, especially when there's suicidality and they're in really dark places. And when the symptoms start to return, they say, see, it's hopeless. I'm never going to get better. And what they don't understand is it may not be, anything that's going on with you. It may just be that you're not getting the quality treatment that you're paying for. And so this is why, like, I think giving them the quality care and giving them the quality support and tracking outcomes and, setting treatment goals is so important. That way, even small increments towards their goal, it shows them, okay, I am making progress. Like, yeah, maybe some depression came back in, some anxiety came back in, but, like, here is the progress that I'm making. And so this is why I think it's important to ask, okay, what happens if symptoms return? And what I would call a good clinician should say, well, maybe we look at how we administered it the first time. Maybe there's something that we need to change up. Maybe you do need to work with a therapist. Maybe there's a different modality that we need to work with, because even within psychedelic assisted psychotherapy, there are different modalities around that. So, these are things that a treatment team would be able to answer. But also the other thing I see is even if they are already seeing a therapist, like that to me, and I know a lot of times this doesn't happen in our practice for whatever reason, but communicating, getting a release of information to be able to talk to the person that they're seeing full time. So even if there is a ketamine-assisted psychotherapist that is working with them, also getting their history and going, okay, what are you seeing? Or even pass-ons to, here's something we've been working on. Maybe this is something that you can reinforce in your session. Like, this is a team collaboration, and I don't see a lot of prescribers doing this. And even other things, like if, say, someone else is doing the bulk of their med management, even getting a release of information to get their full list of prescriptions can be helpful. And, and I know that, there's a database that you can pull up a lot of it, but there seems to be a disconnect because sometimes they'll be prescribed things that aren't in the system. And so even getting a release of information for, so if you're recommending that someone goes, recommend that they sign release of information so that they can talk to their primary therapist, and they can talk to the person doing their med management. Some common misconceptions. So as I've said, there is this common misperception that ketamine heals trauma. And ketamine doesn't heal trauma. A lot of times it does have to process through the body. You do have to work with the belief systems. It will work for symptoms, but it doesn't heal the trauma. And I think this is the disconnect between what I call the medical model, where it's just like, come on in and get your antidepressant, and actual therapeutic work. The second one is that more ketamine is better. Like I said, there's a specific modality that I'm trained in, and it's more interrelational. It's called PSIP, and it uses the relationship. A lot of times there are attachment wounds, and being under the medicine and being in relationship with someone and working on those attachment wounds can actually be more beneficial, especially for someone with these types of wounds. And so, and those types of sessions can't be done. Well, I mean, they can, because you can keep them in their cognitive mind at pretty high dosages, but it's not effective. And so there is an optimal dose if you're working in this more relational way with the medicine. And again, this next one, if symptoms return, the treatment failed. And that can be true. And I would say, to reword this, if symptoms return, the client has failed. Because it's like, okay, we need to relook at this, like what are some things that we can change up? And this other one, this is a common one, especially amongst people in the psychedelic community. A lot of times we will have these beautiful, insightful sessions. We come out of it and we're like, okay, wow, I'm great. But what I've typically seen is if there's not integration, then there's not true healing. And of course there are exceptions to everything that I'm probably saying, but it's just generally not been my experience. And a lot of times what that turns into is then they're chasing the next experience. So again, there are exceptions, but generally speaking, it's just not what I've seen. So what good ketamine assisted psychotherapy looks like, and this is really just kind of driving this home: a thorough screening, both a medical screening and a mental health screening, clear, informed consent. This is, like even things around touch, because sometimes during sessions, clients will ask me to hug them. And that a lot of times goes to their sense of safety, their sense of connection, and what I've seen, I haven't seen research on it, but what I've seen in the sessions that I've sat with is a lot of times it will reopen that priming period, that usually happens, in that very early childhood, where they can recreate that sense of safety, that sense of connection. And so what I will ask a client is, hey, a lot of times during sessions, people will ask me to hug them. If you do that, how do you want me to respond? Or if you need grounding touch, where would you like me to touch you? Do you want me to touch you on your foot? Do you want me to touch you on your hand, on your shoulder? Like, where would you like me to touch you? And so these are things that the informed consent should walk through. And a lot of prescribers will overpromise, and so this is even something that they need to walk through. Again, the preparation sessions, I do at least one 90-minute session intake, if not multiples. The first one gets billed as an intake session, can be billed to their insurance, and then, generally, we can get a lot of material from the first intake session, but sometimes it does take multiples before I even feel comfortable, taking them into the medicine, or think that it's therapeutically indicated. This collaboration between providers, this integration support, defined treatment goals, measured treatment goals, outcome measurements. Are we tracking it? Like this is what good ketamine-assisted psychotherapy does. But also respect for client autonomy, because a lot of times that there's this projection, this transference onto the therapist, and just that constantly turning it back to, this is your inner healer, this is your inner wisdom. We want to get to your answers that are going to work for you, and just a collaboration along the way. a lot of times I get people that come in and they will say, I think it's important that I tell you that I'm a Christian. And I'll say, hey, don't worry, I'm not in there planting any ideas. Anything that we discuss before the medicine is the only thing that will, like come in as new information as far as working with belief systems. I'm not deciding what belief system is best for them. They're deciding that for themselves through our preparation, and then that is what I will reinforce during the session. I call it seeding the session. But another thing that good session would be support on the front end and back end. Like I said, taking care of things, but also I talk about sanitizing their environment, even what they consume, both food, but also like social media, watching the news, that sort of thing, because we are building new neural pathways. And it's not like you have to put yourself into a bubble. But, I have, seen this is where having a good team can be important. Because even working out, I've seen prescribers or nurse practitioners that come to hook up the IV, that they will be talking about their bad day. They'll, they'll be having chit chat that isn't therapeutic. And I've had, people that I work with say, at first I thought you were just doing random chit chat. And then I realized that you were actually working therapy into the conversation, like as I was hooking them up. And I'm like, yes, because this is what we are seeding their session with. This is what they are taking into the medicine session. And so you, especially in that period right before it, you want to, make sure that what they take into the medicine is therapeutic. So, and then this is my biggest concern. Because what I've seen, because there are operating costs associated with it. The ketamine itself is ridiculously cheap, especially when you look at how much people charge for it. But they do have to have a DEA license. They do have to have malpractice insurance. There is whether they're renting a facility, utility costs, that sort of thing. But what I see is a lot of the clinical decisions get made based on money generation. Income generation, revenue generation. And it's not necessarily what is best for the client, it's what will make us the most money. And obviously, like, not having, an additional person that you have to pay sitting in the room with them can, make more profit for the business, but it isn't necessarily what is therapeutically best for the client. And even this booster dependency, it's easier to keep the same clients than it is to constantly bring in new clients. And so, and not to say that this is everyone's motivation for telling them to come in for a booster, but I do think that we need to be more intentional about telling them to use this period, so that even the time between boosters can be extended. Instead of every 4 weeks, it could be every 6 months. But it's to decrease the dependency on the medicine. And again, a lot of times there isn't this outcome tracking, because they're just pumping clients through. They're trying to bring in new clients, and there isn't a lot of effort put into even setting goals, but tracking goals. A lot of times when it's a business, there isn't that therapist involvement, and like I said, a lot of them do become high volume infusion centers with 10, 12 rooms, and they're just rotating them out on the hour. And this becomes an issue when these things become a business, versus the focus is on how can we create the best outcomes for our clients. And part of it, the clients are thankful for symptom reduction. Like a lot of times, this is the first time that they felt like getting out of bed. And so a lot of times clients won't understand that, yes, it's improvement, but it's not the quality care that you could be getting. And so this is where I think it's important for us to advise our clients on what is actually the therapeutic best that they can pay for. And so this is, where I'm going to conclude. The medicine is only part of the treatment. In the medical model, the medicine is the only thing that they're concerned about, but in a ketamine-assisted psychotherapy, the medicine is only part of the treatment. The relationship is another part of the treatment, the preparation is another part of the treatment, the integration is another part of the treatment. And again, I say this to everyone I know, like, ketamine opens the door, but what matters the most in this whole model is what happens after that door is open. Like, you have this window, it's like, how do we use this window? And a lot of times this is where the intensive therapy comes in, so that we do get the best treatment options. And so I am available, like I said, if anybody wants to do any sort of consult. My email, I should have written it on the slide and I didn't, is Kim, Kim, at expansivelove.org. And that's expansive, EXPANSIVE, love, like LOVE.org. So if you'd like to do a consult, if a client would like to schedule an intake or a consult, just let me know. I'm always available. Like again, my gift is I do have a military retirement, and I really just want to help people. So feel free to reach out. Okay, we're gonna stop there.